Yeah. Good morning. I'm very happy today to introduce two speakers. Uh, we have Miss Alka Shrikande. She is founder of Maina Foundation. Alka is a biochemist by training, and she has worked in the area of drug development with several companies, including Pfizer and Bayer. Maina Foundation, she started in memory of her mother who died with breast cancer. Her foundation is dedicated to increasing awareness of breast cancer, promoting early detection, and offering financial help when it is needed to the women with breast cancer who can't afford chemo. Dr. Padma Shetty is a graduate of SET GS Medical College. That's where I come from too. And she has done her postgraduate work in preventive and social medicine. Currently, she heads the Department of Community Medicine at the Somaiya Medical College in Mumbai. She has extensive experience in public health, has worked with many prestigious organizations, WHO, Pathfinder International, Aga Khan International, and so on. She has also worked as a consultant in the area of TB and HIV, and her work has been actually adopted by the state government of Maharashtra. Currently, she is working in the breast cancer screening project. Now, the way I got to know about Alka was through a friend who recommended that, she has started this foundation. And at that time, we were just getting to know about the eye breast exam. And I'm sure that they will talk much more about it today. And so I connected with Alka, and today it is going to be an interesting talk in terms of understanding how exactly that device has helped uh, managing women with breast cancer or screening really for breast cancer. And I will now ask Alka, please take over and welcome. Thank you.
Thank you. Good morning. I am Alka Shrikande. Thank you all for joining us on this Saturday morning. I would like to thank IDS and Neela Vora for inviting us to talk about Maina Foundation and our work. We are truly honored to get this opportunity. So I will start out by giving an introduction about Maina Foundation, how we started it, our mission and goals. And then I will turn over the talk to Dr. Padma Shetty, who has been overseeing a program set up with their hospital since 2013. At the end of that, we will open this up for questions and answers or any more information if the audience needs. So we will start out now by sharing our screen. Prashant, you can share the screen.
Yeah.
So what is the vision of Maina Foundation? And our vision is that no lives lost to breast cancer. So the next slide shows how we started. So in the year 2006, my mother, Maina Pandit, lost her life to breast cancer. So she was an inspiration to us to start our work. My father and I, along with a dear friend of ours, Bharti Gupta, decided to start an organization for the benefit of women focusing on breast cancer. So that's how Maina Foundation was born in 2008. The next slide talks about our mission. So our mission is to reduce the loss of life to breast cancer by raising awareness of the disease. The fundamental need in many countries is to raise awareness of breast cancer, bring information to women, especially those from underserved communities, because very often this women's health is neglected. So when breast cancer is detected, it is in the later stage, raising the mortality due to breast cancer. We facilitate access to screening, such as mammography and clinical breast examination, because breast cancer, if detected early, is treatable. And then we provide assistance with the treatment to women who are diagnosed with breast cancer, such as chemotherapy and radiation. So we want to create some health equity by reducing the burden of breast cancer in women from underserved communities, because very often they are also financially constrained. So the next slide shows our comprehensive approach to address the #1 cancer affecting women. So the path we take is, first of all, raise awareness within the communities, screen for cancer, as I said, through clinical breast exam and mammography, offer chemotherapy to women who are either diagnosed with breast cancer through our awareness programs or in general with hospitals. And then lately we have been thinking of also adding on a palliative care arm to our approach, because as I mentioned, women when diagnosed are often late stage and we want to make their lives as comfortable as possible. So the next slide talks about our impact. So the model of Maina Foundation has been through collaboration. So we set up collaborative work with hospitals and community centers. We provide the necessary funds to initiate and set up the programs, and the hospital, through their own staff, or they hire staff through our funds to carry on their programs. So over the years, for the past decade, we have had a significant impact so far. Thousands of women have been reached out to raise awareness in the communities. We have screened a lot of women. Maybe this number is an underrepresentation, but as I said, through clinical breast exam, through mammogram, through the iBreast exam device, we have screened a lot of women, and then also offered post-surgical treatment such as chemotherapy to hundreds of women. So the next slide shows our reach. Majority of our programs are in India. They are not concentrated in any one area. It's all over India, as you can see, in Mumbai, Nagpur, Chennai, even the north of India, like Rishikesh. So as a majority of the programs are in India, because that's where our reach is, that's where the need is. But we also are open to initiating programs elsewhere. And we do have one with Metropolitan Hospital in Manhattan in the Harlem area, which we initiated in 2019. And we also screened 15,000 women in Brazil in collaboration with UE Life Sciences. And that's the iBreast exam, which Neela was talking about. The next slide shows some of the programs which are ongoing. Now, this is not a comprehensive list. Over the years, we have had numerous programs, but I will highlight the Metropolitan Hospital. So this program is being run by Anita Srinivasan. She heads the breast cancer care center at this hospital. And so the hospital is set predominantly in low-income area with Hispanic and African American population. The women do get the mammograph there, but in case they need advanced diagnostics such as MRI, PET scan to identify and localize the breast cancer, they do not have insurance which covers it or the funds to do it themselves. So the program which we have started there is to fund women who are in need of advanced diagnostic through the through Maina Foundation for better treatment. The next program is with the next slide is with All India Institute of Medical Sciences. And those who are familiar with AIIMS know that these are very prestigious hospitals all over India. The one in Rishikesh is a fairly new one. Now, Rishikesh is in a state of Uttarakhand, which is north of India. This state is very hilly, mountainous, and in fact, Rishikesh is the city which from where the river Ganges originates. So it's very scenic. However, because of the terrain of the area, it's very challenging for women to go to the hospitals and let alone get screened for breast cancer, because first of all, we have to raise awareness in the rural areas. So we started this program in 2018. And they have actually these outreach workers who go into the local communities away from the urban areas and talk to women about breast cancer. They hold camps there, they give seminars and encourage women to come to the hospitals and go see doctors for their regular checkup. And through this program, we have reached thousands of women. It's been a very successful program. Of course, because of COVID, some of the outreach programs have been stalled, but we hope to continue it because I think since from April, we'll be starting all the programs again. So the next slide shows the work which we initiated, as I mentioned, in 2013 with Somaiya Medical College. This is located in Mumbai, in Sion, and is a private hospital which has been around for a long time. So the surrounding areas near Somaiya hospitals have a lot of settlements. These are migrant workers who come to Mumbai in search of jobs, and then they set up their dwellings around the area. So there are the areas like Pratiksha Nagar, Gautam Nagar, and these are inhabited by people from other parts of India, low-income communities. So we initiated this program with them to go into the communities and talk to the ladies about breast cancer. They already had programs going on for other indications such as heart and diabetes. So they added on the breast cancer arm to this. They also hired outreach workers who could talk the language with the women and tell them about the risk factors of breast cancer, how to do self-breast examination, and once again, encourage them to go to the hospital for further treatment or diagnosis. And I don't think I want to elaborate more on this. Actually, I should not, because Padma will be talking more about it. So this program now is in its 9th year. It's actually expanding into a different area, and the impact, once again, has been significant. So the next slide shows the areas around Somaiya Hospital, which I was referring to, the dwellings, and these are those huts in that area. And the next to it is actually a blueprint of all the house numbers and the outreach workers which have been hired and trained by Somaiya under the leadership of Dr. Shetty, go door to each of these dwellings and talk to women and keep a track of them. So this is a mammoth undertaking over the years, and it's really significant. It has been published in papers, and we would be happy to share this work with the group if they do need to read it. Okay, the next slide is our work with India Development Services. As Neela referred, in 2018, we came to know of IDS through a mutual friend, and we started talking, Neela and I, about our work with Maina Foundation. And just around that time, she was also talking to Mihir Shah, who is the CEO and co-founder of the iBreast device. And
Can you please go ahead?
पण लोकांसाठी येत नाही त्याला ऑरेंज कलर
So we wrote up a project proposal to use this device in the community program that we have ongoing with Somaya Hospital for the outreach program. And they provided the funds, part of which were used to acquire the unit and the other for the operation of the program. And once, this is a small unit, which is a handheld portable device. And it's very conducive to going into areas away from the hospital. And once again, as I mentioned, Dr. Shetty will be giving us more information on this. So the next slide talks about more of Maina Foundation. You have seen our goals, some of the programs, and our goal is to keep on going, fund the programs which are already going, like the AIMS, the Rishikesh, and we would also like to increase the treatment which we offer to women for chemotherapy and, as I mentioned, the palliative care. The next slide gives an idea of where our funding is coming from. So this is a small nonprofit foundation. It's strictly volunteer-based. All majority of the funds we raise are given towards programs. And over the years, we have received grants from other foundations, the most recent one being the MJS Foundation or the Simon Foundation in New York. We have had some fundraisers like walks, both in US and in India. We had a gala function. The past 2 years, I have to say, have been, again, a little challenging because of COVID, but we hope to resume all our events starting from the middle of the year. And of course, we have a group of donors, private donors, who over the years have been giving us generous funds. And we truly, truly appreciate the support because it shows the confidence and the trust they have in the work being done by the foundation. So the next slide gives some information about the foundation in case anyone wants to reach us. We have a website, which is, and we are registered in US and in India, a tax-exempt foundation. And then the next slide, which is my last slide, shows a list of the board members and the strategic advisors, which Maina Foundation has. We have a group of, a really dynamic group of professionals. They all have very illustrious professional careers, but however, generously volunteer their time to Maina Foundation. And I want to thank each and every one of them because they have been with us now for almost 10 years. Thank you. So at this point, I think in the interest of time, I am going to pass this on to Padma. Dr. Shetty.
Yeah, thank you.
Yeah, thank you, Alka. And thank you to Alka and Dr. Neela Vora for giving this opportunity to us because it's been a really long experience of 8 years, and I'm very happy that I have got this opportunity to share my field experiences. I'll share my screen. Uh, can the host enable screen sharing for me?
माझा व्हिडिओ ऑन केला नाही आता आपलं दिसतं हे झूम मीटिंग माहितीये ना
Mr. Prashant, can you enable the screen sharing for me?
Yeah, just give me a minute. Yeah.
आणि झाले त्याला दिसता
Okay, you should be good now.
Yeah.
And Prashant, could you mute everybody but Dr. Padma? There is some background, conversation going on.
Yeah. Okay.
Thank you.
Yeah.
Yeah.
So unmute yourself if you need to talk.
Yeah. So I think now my screen is visible. Yeah, so to begin with, I would like to share some of the statistics, Indian statistics. As Alka mentioned that we got the funds in 2013 and we started our program on 1st January 2014. And at that point of time, if you see the statistics, the incidence rate was 36.1 per lakh and the prevalence rate was 92.6 per lakh and the mortality rate was 12.7 per lakh. Now, even now in 2020, the figures don't seem to have changed much in terms of incidence rate. And the mortality rate has, however, shown a slight increase. So this definitely shows that there is a need for the program to be continued, because we definitely need a dedicated program to focus on the breast cancer, because the incidence rate and the mortality rate is high. So the mortality rate is high because the women do come very late in very late stages for diagnosis. So the aim of our project has been basically we want to inculcate this practice of undergoing preventive health checkup in women. As you all know that in India, we don't have the practice of undergoing a preventive health checkup, be it literate or illiterate, it doesn't really matter when it comes to undergoing health checkup. So our aim has been that, we want the women to undergo health checkup at regular intervals for different diseases. And in this project, we focused on the breast cancer. So our objective is to create awareness of breast cancer in women, because without awareness, they would not go for further screening. The second objective has been to motivate women to undergo an annual breast examination. Initially, we had only clinical breast examination, but we introduced the iBreast device in 2019. And we also want women to undergo a mammogram once in 2 years. Our third objective has been to train women above 30 years of age on self-breast examination. So with these three objectives, we have a 6-pronged strategy, where our first strategy is we enlist all the beneficiaries in the project area that we have adopted. Initially, it was age 40 and above, and later on, we reduced the age to 30 and above. The second strategy is to create the awareness of breast cancer. The third strategy is to teach women about self-breast examination. I know that self-breast examination does not have that much evidence to support for breast cancer screening of that. Self-breast examination will help in early detection of breast cancer, but nevertheless, it's important considering the fact that we do not have facility for clinical breast examination or mammograms available so easily in India. The fourth strategy is annual clinical breast examination. The fifth strategy is mammogram once in 2 years. And our sixth strategy is referral and follow-up. The project has been predominantly focused in the urban Mumbai area, that is on the left side. As you can see, this is our urban health training center in Pratiksha Nagar, where the project has been running from 2014. This is just 2 kilometers away from the hospital I work in. And we started off in the urban area, but my entire team and all of us got so involved in the breast cancer that we also expanded our program to the rural area in Raigad district and in the Thane district. So let me just give you a glimpse of the timeline that we have gone through. Actually, this program has been very, very dynamic, and thanks to Alka, we have been allowed to make these changes and adapt to the changing needs. The changes had to be made because there was a demand by the community, as well as there was a changing scenario, because of which we couldn't just stick to what we had planned in 2013. So let me start with what happened actually in 2013. Once when we received the grant, in 2013, we started developing the material for use in the community. And when I was field testing the health education material, I received a very unusual response from the community. I would say it was unusual because we are used to going into the community, knocking on the doors, telling them about health related issues, motivating them to come to the health center. So for us, it was not something new. But when I went with the aim of talking about breast cancer, I could see the fear in the eyes of the women. They were just not open to listening about breast cancer. I mean, there was so much fear that the women just shut the doors on our faces, saying that we don't have cancer in our family. I don't want to listen. This was the beginning. And this really made it, a challenge for us. How do we go about creating awareness when the women are just not willing to listen to cancer? The word cancer itself was denoting fear for them. So what we thought, why not start on something neutral topic, a topic like hypertension and diabetes, because in the community it's okay to have hypertension and diabetes. It's sort of accepted to have this disease. So we thought we'll make a beginning by initiating the screening for hypertension and diabetes. And we began this way in the first year, that the outreach workers, we had 2 outreach workers, because the project was running in 2 pockets of Pratiksha Nagar. One was the slum area and another was the low income buildings. So we started visiting these houses and offering these services. This paved the way for us to talk about breast cancer, and we slowly began our work. And during the first year, we were visiting the houses very often. And we had to do this because the women had to be sensitized about cancer. So over a period of time, and also the fact that we started with the mammography camps within the community, we were able to gain some visibility. And with this visibility, we were able to expand the program in the next year to another area within the Pratiksha Nagar community. Here in 2015, what happened was that we realized that in 2014, the women below 40 years of age were also coming to our clinic for breast related issues. And we felt the need, therefore, that we need to lower the age of our beneficiaries and start at age above age more than 30 years. At the clinic, we also started adding the component of anemia screening, because this was felt need of the women. The women felt that every year we have to come only for breast cancer screening. So this was sort of not it was not a sort of motivation, like they wanted more services. Of course, our health center provided many clinical services, but on the day of our weekly clinic for breast cancer, we were having only screening for breast cancer. So the women felt there was a need for more services. So we had to add on components as we progressed in the year. From 2014 to 2016, we used the approach of mammography camps for doing the breast cancer screening along with the clinical breast examination. In the first 2 years of the program, that is in 2014 and 2015, our visits were more frequent. Like we were visiting quarterly every house and enumerating the beneficiaries and motivating them. In a span of 2 years, our visibility was more. And in 2016, we reduced the frequency of our home visits. And we also added the component of screening for cervical cancer, hypertension, and diabetes. And we stopped the home-based screening for hypertension and diabetes. In 2016, we expanded the program into rural area, initially in Raigad, and subsequently we started in Thane district. So the project in Pratiksha Nagar was in the first phase running from 2014 to 2018. And in the last 2 years of the first phase of the project, that is in 2017 and 2018, we had this mammography referrals instead of the mobile mammography unit. We had to make this change wherein from the mammography unit, which was providing the services in the community, we had to shift to a referral based services because of issues related to parking of the mammogram unit. I will show you in the pictures later on. So that's how that shift has occurred. In 2019, at the conclusion of the 5 years Pratiksha Nagar project, Alka came up with the idea that why not felicitate the women who have undergone breast cancer screening. I mean, these are mostly women who are housewives, and nowhere they have ever been felicitated. So the women were invited for this program, and over 100 women who had undergone regular clinical breast examinations were felicitated in this program. This program exactly happened 3 years back on 26th March 2019. In 2019, we also expanded the program to a newer project area again within Pratiksha Nagar, and we also added the iBreast device screening. So this is what happened in 2019. And because of the pandemic in 2020, the activities got suspended in mid-March, and we were not able to start the services again till end of December 2020, where we slowly started reaching out to the community again. But the response from the community post-COVID was very poor because they were reluctant to having anybody visiting their homes. And also there was fear of coming to the hospital for an examination. So we have begun very slowly. And again in 2021, there was a surge in the cases of COVID-19 in Mumbai. And so again in the month of April, after 30th April, we again suspended our activities. Now, however, the program has again started, and we hope to see some good results in this. Now, let me talk about the challenges that we have faced and the successes that we have. One of the tasks that we did was to enumerate the beneficiaries. And in order to enumerate the beneficiaries and keep a record, we had this family folder in which the details of all the family members were kept. It was a paper-based system, and we contacted in Pratiksha Nagar 2,000 houses. 52% of the population was enumerated, and there was almost 2,230 women who were above the age of 30 years. The challenges for enumerating the beneficiaries have been immense. the layout of the slums is very complex, and one of the maps which was shown by Alka, you could see that it was very intricate. It's literally like a maze, like you can get lost in the slum if you do not belong to that area. So that layout of the slums has been complex, because of which we had to go in for the maps. There were some segments of the slum pockets which were unsafe for the women, and it was difficult for women to go into those areas. Of course, we did not cover those pockets of slums which were unsafe for the women to for my health worker to go. Another challenge we faced was, how do we track these women back again? If my outreach worker left, any other person I would send to find the women again would have been difficult, because not only because of the complex layout of the slums, but there were no house numbers. So the identification of the house itself was not there. And there were multiple numbers. So that again was a big challenge for house. Another challenge was, like, in our next visit, which would happen, say, about in 3 months' time, we would see new houses being constructed. And therefore, there was a constant change in our population. Majority of the women, like almost 50% of the women in this eligible age group, were not available at the time of our visits to their families, which happened during the between 9 to 4 p.m. And this was because most of them were working. Our second strategy is creating the awareness. So in this, we had two strategies. One was house to house. We went and spoke to the families, and you can see here in this picture, my health worker is talking to the women of the house at the doorstep. So almost 10,000 health education interactions have happened in this past, in the 5-year period. And at least 1,476, that is 66% of the women received health education. Here again, the challenge is, apart from the fear of discussing about breast cancer, the issue is also lack of privacy. When there are male members present in the house, usually their houses are like 100 square feet. So if there is many male members in the family, the women are a bit reluctant to discuss or talk about breast cancer. Also, they are busy with their household chores, which meant that they would not be able to give us adequate time to listen to our health talk. So we had to sometimes be really very quick in delivering our health education message. Our other strategy of creating awareness has been the group awareness, where we have conducted 64 awareness programs and 2,500 women have received health education. In the Pratiksha Nagar community, we did not adopt the group awareness session as a strategy, because there was difficulty in finding a space within that community where such programs could be held. However, we have conducted group awareness sessions in educational institutes or in women's organizations outside Pratiksha Nagar, and in the rural area, we have used the strategy of group awareness. Sometimes the challenge is that if the mobilization has not been done effectively, then we have a low participation rate. So here we need to always take the help of existing group which is there for community mobilization. Our third strategy is self-breast examination, in which we have trained around 1,400 women in self-breast examination. These women were mostly trained at home, but we also have trained them in the clinic or reinforced the technique of doing self-breast examination in the clinic. During our quarterly visits in the first 2 years, we inquired about the self-breast examination practices being followed by the women, and it was found that 50% of the women who were trained were doing self-breast examination, but it was not a monthly self-breast examination. As and when, whichever month they remembered, they were doing it. So it was irregular, but still 50% were doing. The challenge of doing a self-breast examination was lack of privacy. As I mentioned, the single rooms, no attached bathroom. As you can see in this photo, this is a single room and there is no privacy. The presence of male members, all this hinders our training in self-breast examination, as well as in the women doing the self-breast examination on a month-to-month basis. Our fourth strategy has been the annual clinical breast examination. For this, in Pratiksha Nagar, we have a weekly clinic which is held on Tuesday. Initially, it was a weekly clinic, and subsequently, we also had a clinic on every day, almost every day, 4 to 5 times in a week. And 45% of the women whom we had enumerated had done at least one clinical breast examination. And overall, if you go to see, there were 4,700 women who have been examined by our physicians in the period of 5 years. And the abnormalities that we detected were 13%. It is, though it is a cohort study, it's a cohort of women whom we have been following up for 5 years. What we realized is that women become a little bit complacent about doing a about doing a clinical breast examination when they get a normal report in the first 1 or 2 examinations. And so they feel that why should we undergo clinical breast examination again? My last exam findings were normal, so I don't need to do. So this has been one of the reasons why, not all the women have undergone a clinical breast examination in 5 years. If you look at the data of clinical breast examination, in 2014, we had about 450 CBEs, which went to 626 women, and then it started dropping. And again, in 2019, we saw almost double the clinical breast examination. This change, which we observed in 2019, was due to 2 reasons. The first reason is we had expanded our program to a newer area. So in the first 5 years, it was only the Pratiksha Nagar slums and the low income buildings of certain pocket of Pratiksha Nagar, whereas in 2019, we started covering more buildings in this period. Also, what happened in 2019 was the iBreast device was introduced, which again helped us in increasing our numbers, especially for those women who were reluctant to undergo the breast cancer screening repeatedly. So this is what happened in 2019, and again in 2020 and 2021, as I mentioned, due to COVID pandemic, we had to suspend our services, routine services, and the numbers have declined then. What has been challenge for doing clinical breast examination? We have conducted a qualitative study in which we found out what were the barriers for doing a clinical breast examination. And mainly the reasons that have come forth in our study are the fear of being diagnosed of breast cancer. Also, there was an anticipation of undergoing this checkup, that if they're detected with the disease, there will be a financial burden. The household priorities was another reason why women were not willing to take out the time to undergo the checkup. There was lack of family support, which was evident in many of the families where the male members of the families have stopped the women from attending the clinical breast examination screening. Also, some of the women have fatalistic attitude, believing that if it's in their destiny, they will get breast cancer. So they didn't want to do anything about it. And some women felt that since they did not have the family history of breast cancer, they need not undergo this screening. Some of the clinic related issues were that though the waiting period for the women was not much, they had other priorities, and therefore they felt that the waiting period at the clinic was more. The space and privacy for CBE camps, which we have conducted in rural area and in some parts of Mumbai, we found that identifying a space where we can do clinical breast examinations and offer that privacy to the women has been challenging. The time and day was inconvenient for the working women, and therefore we were not able to approach those working women. There were also some other barriers to clinical breast examination. Of course, these were not cited by the women, but it's been our experience that we require to have a female physician for these clinics. And though clinical breast examination we are taught in medical schools and we know about it, again, we need to train the physician to do a clinical breast exam. Coming to iBreast device, which we introduced in 2019, there were about 1,000 women who have been screened with the iBreast device, of which 3.7% had abnormal findings. So this gray and pink one is the iBreast device. This pink circle is the sensor area, which we apply it on the breast tissue, and the findings are reflected on this mobile screen. The breast tissue, as you can see here, is divided into 16 quadrants, and a normal breast examination finding on an iBreast looks like this. It will look completely green if it's a normal breast tissue. If there is any abnormalities, it shows as a red zone. So this is an abnormal IBE findings. Some statistics related to clinical breast examination and iBreast examination findings. So I had some data on 865 women who have undergone both clinical breast examination and iBreast examination. And in this data, what we saw that there were 776 women who had a normal CBE and 89 had abnormal clinical breast examination. Out of those 89 who had an abnormal clinical breast examination, 31 had a lump in breast, and 58 women had other abnormal findings like nipple discharge or an abscess. Out of those 31 who had lump in the breast, 23 were detected by iBreast device, but there were 8 cases which were missed on iBreast examination device. Similarly, in the normal CBE, there were 776 who had a normal CBE, and through iBreast device, we were able to detect 5 women who had some abnormal iBreast examination findings. The statistics available on the sensitivity and specificity of the iBreast device shows that it is 84% sensitive and 94% specificity. That means 84% of those who have the breast cancer will be detected on screening with iBreast device, and specificity means those who do not have the disease, 94% will be reported as negative. So these are the statistics which are available for the sensitivity and specificity, and this has been our experience with the use of CBE and IBE, which we have tried to compare.
Something went wrong.
Padma, are you there? What happened? Did she drop out?
Prashant, I think she dropped out.
Yeah, I don't see her on the participant list anymore. I just checked it. She's
Okay,
not.
let's see. Oh,
Maybe while we are waiting, maybe if people have question, maybe they can ask Alkaji if they have other question or see, because I don't know when.
Should we try to contact her? Alka, can you try to contact her?
yes, I am. I am.
Hmm.
Yeah, so while you're doing, is there any burning
Yeah.
question you want to ask Alkaji?
Maybe this is Mukta. I think
I'm sorry. I'm sorry. I think I lost the connection for a
Yeah,
moment.
Okay, you're back. Okay.
Yeah, sorry. Yeah,
That's
I'm
okay.
back. Is my screen visible?
Well, not right now. I think I have to
Okay.
make you host, but before I do that, I need to make sure I mute some people who have been talking before. So, okay, let me make you host. Okay, you should be good. Can you hear me?
Yeah, yeah.
Yeah. Okay. Okay, we can see it.
Oh, okay.
Yeah. Yeah, so the previously reluctant women started coming in, and one of the benefits of an IBREST device was we were able to get instant results. We could see the abnormalities, and we could also use it as a tool to explain to the women that there were some abnormal findings and she needed to go further for evaluation. Data storage was possible, reviewing and sharing of the data. Synchronizing the data with the Wi-Fi connection at later date was possible, which meant that we could use this in the camps. Some of the difficulties that we found or which were expressed by the women was when we do a clinical breast examination and eye breast examination together, it takes more time. And eye breast examination is a little more time consuming than a clinical breast examination. With an eye breast device, we cannot screen the axilla and the nipple areola complex. And sometimes it cannot also differentiate between an underlying bone or tumor. Since it is a sensors and it is placed directly on the skin, we need to clean the sensors before screening the next beneficiary. It is also essential that we have to charge the device and mobile adequately before we use it on the before we use it for other women. And this also has been slightly challenging because when we were having the clinical breast examination services being offered every day, sometimes it was we did not get enough time to charge our device, so that also was a bit challenging for us. Regarding the mammogram camps and the mammography referral services, between 2014 to 2016, we used the mobile unit. As you can see, there's a pink bus here in which we parked it in the community just outside our urban health training center, and 25 to 40 women would come for this camp. And in 2017, we had to stop this mobile unit and start referring the women to the hospital. We have done 379 mammogram screenings in which we have found 10% abnormal findings. However, no case has been detected only on mammography. majority of the women having come in the late stages. We have had 12 cases. Majority of the women have come in the late stages when the breast lump was quite evident and could be palpable on the clinical breast examination. The challenges for the clinical breast examination.
Hey, Sujata, can you go to on mute, please? I cannot do the mute. Or Padmaji, can you do the mute, because I cannot do mute.
I don't know. I'll just check.
We can click on Sujata and then click mute.
Yeah, I'll just try.
Okay, thank you.
Yeah, so the challenge for the mammography was that when we use this mobile unit, you know, it's very huge bus, and it requires a lot of parking space, and therefore the challenge has been that to find an appropriate parking space. And in 2017 we had to discontinue with this services because there was an increase in the traffic flow over the period of 3 years, and there was also a lot of construction, and we had to then shift to referring the women to a nearby hospital. The mobile unit actually was sort of like an advertisement, because it was so huge, and the visibility was so high that we also got a lot of women from the middle income and high income group buildings who came to inquire, a lot of men coming to ask what is this vehicle for. So this again brought more visibility to our breast cancer awareness and screening program. When we tie up with any such mobile units, we also need to be very sure about the quality of diagnosis, and this needs to be verified by us. Even though we organize this mammography camps in the first 3 years within the community, and it was offered free of cost, there was reluctance of the women to access the services. We had to, even though the women had given their names for undergoing the screening, on the day of the mammography camp itself, we had to give them multiple reminders to come and avail. Also, sometimes the women collected this reports also late. So it was a little bit, frustrating also that, so much efforts have been put in. We have called the mobile unit. My health workers went and reminded them a day before, a week before, and on the day of the camp in the morning. Still, because their priorities were different, they were not taking out that much time to come and undergo the screening. And when we started referring the women in 2017 to the hospital, there was a nearby facility which was like, say, half an hour from the community. There also the women were not willing to undergo the screen. They were not willing to visit that hospital because they felt it was far off. And my own hospital, which is located 2 kilometers away from the field practice area, did not have a mammography services at that time. Now we have the mammography services. So we are referring the women to our own hospital, where we provide the mammography services at a very subsidized rate for the project beneficiaries. All the women who are detected with abnormalities are referred to the Somaya hospital, and there we provide them with the free diagnostic services. The outreach worker accompanies the woman if she feels that she needs somebody to accompany her, and a lot of reminders are given to these women through home visits and phone follow-up, so that at least those who have been detected with some abnormalities go for further evaluation with the surgeon. However, in spite of all our efforts, we have had only 25% successful referrals. Tracking and following up these women has been a challenge, because as you can see, in the slum area, majority of the houses were rental houses, 40%. So they were shifting their houses very frequently, and therefore tracking them was difficult. They would change their phone number. So it was a bit problematic for us to track the women. We use this kind of a tracking register where each woman was enumerated in this register, and her clinical breast examination date was recorded here, the previous one, the current one, the mammography date was written, and the follow-up, like whether she has undergone clinical breast examination, whether she is doing self-breast, all this has been recorded in the tracking register like this. So this helps us to identify the women who need to have repeated reminder visits. We have, in this period of 8 years, we have had 12 breast cancer cases. In the first year of our project, we did not have any cases. In the second year, we had 2 cases. In third year, 4 cases. Each woman is represented by this icon of a lady. In 2018, 1 case, and recently, in the past 6 months, we have come across 5 breast cancer cases, of which 2 of these women whom I've shown in red are not taking treatment. Their family is reluctant and that acceptance is not there. And so these 2 ladies who have been diagnosed in December 2021 have not initiated treatment. Rest all have been initiated treatment and they are right now fine. And this data also shows that there were 2 women who were diagnosed with breast cancer and were between the ages of 30 to 39 years. And therefore, there is definitely a need for doing the clinical breast examinations from an early age. And the iBreast device itself will help us in screening women of a younger age group. This is our first case of breast cancer, this lady in green who was felicitated in our program, Prerna. And over 100 women were felicitated in this event. To summarize, I would say that breast cancer awareness and screening is necessary. You need to have dedicated field staff to motivate women, because somehow women tend to neglect their health and they need constant push to take care of themselves. We also need to have camp approach through involvement of groups and institutions. And some women need financial support for diagnosis and treatment, which of course has been provided to us through Maina Foundation. And with this, I want to end and thank you everyone. And this is a poster which was created by one of the girls in our poster competition held in October, I think 2017 also. So thank you everyone.
Can we now? Yeah.
So we can have any questions.
Thank you, Padma. This is Neela. I just wanted a quick question.
Yeah.
Padma ji.
Yes.
You know, I can understand how hard it is to reach out to all these women with changing phone numbers and so on. Because my first question to you was going to be about, contacting the women with phone numbers. But the other question, which I want to go back to your slide about where
should I project?
Clinical, no, it's okay. Clinical breast exam where you found the lumps.
Yes.
I actually missed on iBreast exam because that is one of my concern.
Yes, they were missed on iBreast examination.
Was it because, is it a kind of technician dependent exam? That is why what I'm asking is the women who were screened, were they, or the people who were doing the technique, people who were actually doing the exam?
I think it was not technician depend, maybe it was close to the areola region. So that is also a reason where it is missed. And we did find this. In fact, one of my colleagues who routinely does who has been using the iBreast device more often, Dr. Manisha, if she wants to add, she can add. Manisha, would you like to add something on this?
Uh, uh, yes, ma'am. Actually, we could find the small lump which was near the areola, and that was missed during the eye breast examination. Also, we do the axilla screening, axilla palpation during the clinical breast examination. So their findings also be missed during the eye breast examination. That is why those are the figures.
So could the iBreast device actually not go up to the axillary area?
Yeah, ma'am. We cannot examine the areola as well as nipple and breast. Sorry, the axilla region with the eye breast device.
And
That is the area which we should not go for the examination.
right. So the second question is, can you give the comparison between sensitivity and specificity of mammogram versus iBreast? Like you showed 94% sense specificity.
Yeah,
and
mammogram is the
94%.
gold standard.
No, so what is the
Yeah.
sensitivity and specificity?
Yeah, I don't remember that. I mean, I'll have to look it up and say. But here we have not compared it. The sensitivity and specificity has been quoted by UE Life Sciences, and it's there on their website. So I'm not able to answer that question on the mammogram sensitivity and specificity right now.
No, just like what is the data available in the literature for sensitivity, specificity? Does Dr. Manish know? No.
Yeah, I will have to look it up and tell you. I'm sorry at this
No
moment.
problem. No
But
problem.
it is the gold standard, so it would have high sensitivity.
Yeah. Okay, thank you.
Yeah.
Anybody else has a hand of Madhukar? Do you have any questions for Alka?
No,
Madhukar was the
came
one
in
who.
very late. I was gone out and I just came in for the last few minutes.
Oh, okay.
Yeah. So hi, this is Prashant. I had a question. I was surprised to see only so few cases were detected percentage-wise, because I would have expected that, this is a very prevalent disease. So is it because the people who are likely to get this disease are not coming for exam versus the more younger crowd comes, or they don't have it right now? Was this the reason? Because that number of cases over the year is like so few comparatively, right? So I was just trying to figure out what is the reason compared to what is reality, right?
So here I would like to say that these are the number of cases we came across, and it is not that every woman would have revealed that information. See, there was only 50% of that entire population we were able to contact. And some women have hidden this fact that they have the disease also. Okay, so they may have the abnormality, but they do not come and tell us. Like we have come across cases after 2-3 years, they have told us that they have a breast cancer. So unless the woman comes here and tells us, we wouldn't know about it. It's only those women who have come to our facility that I have reported this information mostly.
Yeah, but even those who coming in, right? I think
Yeah.
percentage was still fairly low. So that's what I was wondering. There must be some reason for not, or maybe people who are really problematic are not coming. That might be one of the reasons.
That is more likely. That is more likely.
But I think you guys are doing very good work, preventive work, trying to come up with that. So that's really appreciated.
One question for Padma. Can I say, Prashant, can I just answer? Yeah.
Yeah, go ahead.
Yeah.
Yes.
Padma ji, now the camp in Rishikesh, do you know who is doing this work? Now, I know it is AIMS, right? That is doing it.
Yeah,
Have they
Dr.
been using
Meenakshi.
Yeah, maybe
They are using the iBreast device.
Yeah, because I'm wondering, in a camp setting, maybe it will be a lot easier to do the iBreast than actually having the, individual,
Actually, iBreast is a pre-screening tool.
Right.
So where
right.
you do not have physicians and where this facility is not available, maybe the nurses can use this iBreast device as a pre-screening tool, and those who
Right,
are detected
right.
with abnormalities can be referred.
Yes.
However, in our clinical settings, and because we are located in Mumbai, we have the facility of the doctors who can provide these services.
Okay. Thank you.
Hello, can I have ask a question and make a comment? This is Renuka Dulala.
Hi.
Okay. Hi. So I'm a medical oncologist here in the US. And Dr. Padma, thank you so much for the talk. I think what you're doing is really wonderful work. I can understand how tough it should be in India. So my question, again, going to the sensitivity and specificity of mammograms, at least mammogram sensitivity is much higher. It's like more than 95% sensitive, and specificity is about 65 to 70%. So it's interesting that iBreast, the sensitivity is lower than the specificity. So that means we are missing a lot of, cases. And like you pointed out, it's probably because it's not able to pick up lesions in the nipple areola complex and axilla. Now, coming back again, asking another question along those lines, you said a lot of them, when you say 84% sensitive, and then some of them were picked up, actually more lesions were picked up on the clinical breast exam.
Yes.
Were they actually cancers or were they all types of lesions? When you finally tease it out, is it benign lesions as well?
Yes, benign lesions are also detected, not necessarily cancerous lesions.
I mean,
And
more likely benign. Right.
yeah, there are benign lesions also. Even in mammograms also, many benign lesions have been detected. So that does happen. And many women come with nipple related issues, nipple discharges. Large number of women come with serous nipple discharges.
I see. So, yeah, I mean, I guess you're using the iBreast exam where there's no access to mammography. Is that how it's being used in India?
No, we are using it to complement our clinical breast examination. It's not supplementing mammogram, because if we find any abnormalities, we do refer for mammogram. Plus, if the woman is above 45 years of age and she can go to the hospital for a mammogram, we do refer for mammogram. So this is just supplementing our clinical breast examination services. It cannot replace a mammogram, I feel.
Right, right.
Sure. It's just a pre-screening, but
yes,
the advantage that I can see would be like if a large number of women can be screened by, where women don't have to come to the clinic, but a technician can go to the slum area, and
yeah, we did think about this, but
Right.
What happens is that they take it for granted that everything will be done at home. Like as I told you, when we have parked the mobile unit in the camp community itself, which was right at their doorstep, it's a 5 minutes walk from their houses. Still, they required so many reminders. They were not coming to collect the report. So to some extent, see, if it's a hilly area, tribal area where, traveling becomes an issue, I can understand that we should provide this at home. But in an urban slum where the facilities are available, I think the women should at least take that effort to walk to the clinic, otherwise that importance is not there. Even there was a point when we thought whether we should really provide mammogram free, when we know it costs around 2,000 Indian rupees. We were providing it free. The women were not valuing it and coming and collecting the reports.
So is it because of the social stigma or just a fear?
It could be the fear. It is a tendency that, okay, I'm absolutely fine. It's also that, okay, I have other household priorities. And I think that is the major issue, that we as women do not give importance to our health. and everything else becomes a priority. And preventive health checkup, see, as long as you since you don't have any complaints, there's no reason why you should want to go to a doctor. That's our thinking.
Yes, one more question, Dr. Padma. So do you have statistics now? You've been doing this for some years, right? Almost 10 years.
Yeah.
Now, do you have any idea how many women are actually following or doing their mammograms every 2 years? Because I find even in upper middle class, they do it 1 year and then that's it. It's negative, and maybe 10 years later that they haven't had a subsequent mammogram, in which case there's no benefit at all for a screening mammogram if they just went once and then go subsequently.
Repeat mammograms are not usually seen. Women do not undergo that. Even we healthcare professionals working in our own healthcare institutes, very few women, undergo mammograms, even though it's available in our own hospital.
Yeah. Yeah, it is. Thank you, Dr. Padma. You've been, this is really a very difficult and challenging work that you are doing. And thanks to you and Alka for all the help that you've been giving to these women.
Thank you for giving me this opportunity to present.
Thank you, Neela, for having us.
Yeah.
It's really, as I said, it's good to get the word out of the challenges faced even today in 21st century. And so that hopefully we can all come together and make a change.
Yeah.
No, thank you, everybody. I'm
Thank
going to
you,
stop
everybody.
recording now. I'm going to, and this
Thank
will be
you
available.
for, I want to thank everyone for joining this session. It's been very encouraging, and thank you for giving your time on a Saturday morning.
Thank you, Alka and Dr. Padma, and
thank you.
Thank you.
Thank you.